Dr. Tariq is working at Aga University. He's a professor of medicine. He's working since 2017. He has been the interim associate dean education and chair for Department for Educational Development from 2015 to July 2022. And currently he is the vice dean medical college at Aga University. He served as a section head internal medicine from 2011 to 2017. He has been the postgraduate program director and the program director of internal medicine. He has graduated from Dow Medical College. He's an AKU PGME alumnus, which is postgraduate medical education alumnus, and has completed his residency in internal medicine. He is also a member of the Royal College of Physicians, and he got the advancement of fellowship of the Royal College of Physicians of Edinburgh as well. He has become FAMER Fellow, which is based in Philadelphia, and he was awarded IFME International Fellowship in Medical Education. He has also completed MHP from Maastricht University, and he became supervisor of CPSP residents in 2005, and also examiner of fellows of internal medicine from College of Physicians and Surgeons, Pakistan in 2012. A very warm welcome to Dr. Mohammad Tariq, and his presentation is on clinical diagnostic reasoning. So thank you so much. Thank you, Dr. Tariq, for joining. Over to you.
Thank you, Tabassum, for such a long introduction. So I'm really thankful. So do you have my presentation, or should I try to share?
I think you can share for me because we have connectivity problem over here.
I am having this host disabled participant screening. So I'm disabled from the host side. So can you enable?
Oh, okay. Let me. Yeah, we'll give you the rights. Dr. Mubashir, will you be giving the rights?
Will you allow Dr. Muhammad Tariq to share his presentation, please? Yes, you can now. You can share it.
Okay. So can you see my screen?
Yes, we can see your screen.
Okay, so once again, thank you so much, Tabassum, for this generous introduction. And this is my just second day to joining as a vice dean of the medical college at the Aga University. So I'll be talking about clinical diagnostic reasoning, very close to my heart. I'm an internist, I'm a professor of medicine, and working very closely with the medical students and the residents, and very much involved in diagnosing and treating patients. So I think what I strongly feel that how to diagnose a patient is such an important thing. Okay. So this is a disclosure statement that I have no financial interest, arrangement, or affiliation that would constitute a conflict of interest for this presentation. Tabassum, can you hear me clearly?
Yes, Dr. Tariq, very loud and clear.
Okay, great. So teaching in the clinical setting is demanding, complex, and often frustrating. We have complex issues. You have residents, you have medical students, you have junior faculty sometimes, and staff, nursing, and a number of things. So in the clinical setting, everybody expect from the faculty that he teaches, from the resident, the junior resident expect that they will be taught. The students expect from the senior resident, the junior students, third year or second year student expect from the senior students and maybe residents. So it's all a learning environment which is there in the clinical setting, and sometimes the clinical setting is totally only service oriented. So I think there is a huge difference between institutions where academic clinical setting is created, where on the other hand, in other spectrum, only clinical service oriented a setting is created, and it all depends on the person who is, or maybe system who is doing it. And I think that is quite variable. And I think it's very, very important, if you are in an academic institution, I think there should be an academic setting, and it is demanding, and definitely it takes time. um, Clinical workplace settings consist of, inpatient, outpatient, community setting, and each with their own distinct challenges, including emergency medicine. So the basic things, I think, still holds very, very much true, despite of this enhanced technological era, where all sort of technology is there with us. But I think history taking, physical examination, patient communication, professionalisms are best learned in the clinical setting, and these are still these four components: history taking, physical examination, communication skills, and professionalism. They are still the mainstay in the clinical setting, and those technological things supports this to refine the diagnosis and refine the teaching and training. So medical knowledge is directly applied to patient care. Trainees begin to motivate by relevance. Whenever the trainee start entering into the medical floors, students, they learn, and they try to apply. And self-directed learning is very, very important in clinical teaching. So now this is one of my favorite slides. So clinician and a clinical teacher. Clinical clinicians, as I earlier said, that clinicians are those who just diagnose the patient. Their expectation, they can do private practice. Most of them are doing private practice, just diagnose the patient. That is the role of the clinician. Maybe you may have excellent people who can diagnose in an excellent way, and I think that's fine. But a person who holds a degree of with the academic title, assistant professor, associate professor, or a professor, or maybe a registrar, these are in an academic institution working. Their role is to diagnose a patient as well as they diagnose the ability of the learner. And at this second part, the diagnose the ability of the learner, is a lot of time is missing. In an academic setting, again, most of the clinician, or number of clinicians, just do their clinical teacher aspect, diagnose the patient thing, and a number of students, they learn by just observing. That is again important, because by observation in clinical setting, learners learn. But I think it's very important that they actively involve and diagnose the ability of the learner. And after diagnosing the ability of the learner, they then and there provide feedback. So feedback in the clinical learning setting is very, very important, and I think which is missing in many of the institutions. And I think our job is to continuously remind students and teachers about this. Okay. So doctor ka matlab hi, the meaning of the word doctor is derived from the Latin docere, which means to teach. And clinical teachers have a dual role in medicine, to provide patient care and to teach. I already mentioned that. So challenges of clinical teaching: time constraint, definitely heavily. If you are heavily involved in in clinical work, I think you do not have time. But I think with that heavy work, again, you can ask one or two relevant patient diagnostic related questions, and there you can involve. Work demands: teachers maintain clinical research and administrative responsibilities as well. So I think you need to balance. Unpredictable and difficult to prepare for. Engaging multiple level of students: how to engage students and residents and other staff. What I usually do, when I do internal medicine floors, I have senior residents with me, which is a team leader, and then there are junior residents, and then we have these medical students. So after every second, third patient, I identify a patient related question or relevant issue, and ask a question to the house staff. And the most junior, I ask the most junior person in the team. I start from there, and then do not spend much time on that person. Just move on to the next level, then move on to the next level, then move on to the next level. Sometimes I may get answer from the year 2 level resident, maybe sometimes year 5 student, or maybe sometime at a very senior level resident. But in that way, whole of the team is engaged. I think engaging multiple level students and residents is very, very important, because team structures improves learning. Okay, I think incentives is very, very important for teaching, which is a number of institutions lacking, which is again a challenge. But in spite of that, I think people have passion for teaching and learning. There is a video here, but I think I would like to skip that. Um, or maybe if time we get time later, I'll that run that video. So now in clinical medicine, 56% of the problems can be diagnosed after taking a comprehensive history. As I said earlier, history taking is one of the most important thing, and literature says that in more than 50% of the time you diagnose a patient, and if you're taking an excellent examination, you have done an excellent examination, more than 70% of the time you diagnose the patient. Now, if up to 70% of the patient by time you diagnose the patient, after if you're excellent history and examination, then what you do, still if you have not made a diagnosis, you have a differential diagnosis, and based on the differential diagnosis with priority diagnosis, you diagnose, you order investigation accordingly. So in my mind, if you're taking an excellent history and examination, you are then tailored towards two or three specific diagnoses, then your investigation will be a cost effective. You would be doing only relevant investigation rather than doing everything in every patient. So I think that's important. So history and examinations are important. You see here, William Osler, he is inspecting in the on the left side, left upper quadrant. On the right upper quadrant, he's palpating. On the left lower quadrant, he is auscultating. On the right side, he's contemplating, thinking what is going on. I think right now in our situation, contemplation is significantly compromised. Even auscultation and palpation of the patient is significantly compromised. Just we do non-touch technique is still significantly prevailing, and where a number of things are missed. So thinking process and examination is so important. So medicine is learned by the bedside and not in the classroom. So this was one of my study, 134 trainees, including medical student and postgraduate at tertiary care hospital. This survey suggested that 55% of the ward rounds, they thought that maybe service oriented, but they felt that 90% felt the best part learned in the ward rounds was management of the patient. And the least learning was related to the clinical skills and bedside teaching. And they want 40% considered and 69% wanted the rounds to be balanced clinical, and they are not saying that it should be all teaching going on. There should be a balance. So 69% of them thought that there should be a balance of teaching and learning and service during the rounds. So this was just some of the important clips from this study. Now, patient physician diagnostic competence. Medical errors are important. So imparting diagnostic competence in medical student residents is of utmost importance. We know all. And the diagnose, what we want, our health professionals, our students, our residents, how they develop to diagnose various clinical conditions with little diagnostic errors. It takes time. The junior resident do mistakes, junior students do mistakes, but I think they learn from the senior. They do not have direct responsibilities, but they learn, they write their notes. If we give them responsibility, they do it. So according to the Burner and Graber, 94% of the academic doctors rate themselves as performing within the top half of their profession, and that doctors have difficulty in recalling any errors they make. Overconfidence. So attitude of overconfidence, in that case, they do premature closures and tend to do mistakes. Yes, maybe 70% of the time they may be correct, but sometimes in 30%, up to 30%, or maybe 20%, or maybe 10%, they may be wrong. I think so. So I think again, overconfidence is an issue sometimes with. So educators that agree that clinical reasoning is a central component. And objective to the clinical reasoning are everywhere. Medical schools, licensing bodies, specific societies, ACGME emphasizes on clinical reasoning, Royal Colleges emphasizes on clinical reasoning, WFME, LCME, even PMC, so CPSP. So all the bodies HEC, all the bodies recognizes the importance of reasoning when you diagnose a patient. So all agree that reasoning is one of the major, and the other, it can be also said as problem solving, decision making, judgment, and it should be taught and tested. So as per Norman, from the psychology literature, clinical reasoning consists of dual mental processing and has been either analytical reasoning or a non-analytical reasoning. So I'll spend few slides on these. The non-analytical reasoning is called as system 1, or subconscious pattern recognition, or illness script recognition. And an analytical reasoning is called as type 2 processing. So means that non-analytic, when you see a patient after just listening to a history and examination, you identify a pattern, and there are illness script into the minds of sometimes the senior faculty, senior consultant, and then based on that illness script in the mind, they recognize the pattern, and there is a subconscious pattern recognition, and based on that they diagnose. That's a quick diagnosis, and that's a system 1 diagnostic thing of clinical reasoning. And the other one is analytical, where you diagnose the whole set of data in depth, and then you diagnose a patient. So that's a non-analytical, that's the analytical way of clinical reasoning. So a study have shown that medical students and novices uses mostly system 2 approach, which is the in depth, they look at the data, and experts uses usually system 1 approach. So I'm just sharing a case with you. It's a 43 years old woman brought to the emergency room by her husband at 2 a.m. with shortness of breath. That dyspnea had occurred suddenly at 11 p.m. and had awoken the patient from sleep. She had felt nauseated and vomited a small amount of blood. She complained of retrosternal chest pain that was worse on deep breathing. For several days, she had coughed up a small amount of blood. For 4 days, she had felt unwell and had a sore throat and sinus congestion that has resolved. She complained of having experienced fever and chills on several occasions in the past few days. The previous night, she had awoken with chest tightness, but this has settled after a short while. Her past history included bronchitis. So what is the most likely diagnosis? Dr. Tabassum, can we have some interaction?
Yes, of course.
Yeah. So based on this data, anybody can identify any diagnosis or maybe a differential diagnosis on this based on this data?
You can write in the chat or unmute your mic.
So I cannot see the chat. Tabassum, if you can share if there is something in the chat.
Tariq, there's one diagnosis of pneumonia that has come
Okay,
up.
so pneumonia could be one possibility. Now, what could be the supporting evidence for pneumonia? There is a history of fever, there is a history of cough, chest pain can occur in pneumonia. But what about episodic nature? Could pneumonia be episodic? Could it resolve intermittently? Could the pain would be on deep breathe in pneumonia? Yes, it can be if pneumonia is associated with pleuritis. So yes, pneumonia is one of the differential diagnoses. I would agree with that. What other differential diagnoses you may be considering?
Tuberculosis. The next is tuberculosis.
Tuberculosis, yes, I think you can think about tuberculosis, but it's a very short history. Usually in tuberculosis, you get a prolonged history with coughing up of blood. Yes, coughing up of blood may be associated with tuberculosis, but usually a low-grade fever with a prolonged history, night sweats, weight loss, and other things are associated with tuberculosis. So tuberculosis, from this first presentation, tuberculosis may not be the differential diagnosis I would consider, but maybe if it is a recurrent, taking long time, maybe we can consider tuberculosis one of the differential. What else?
Lung abscess.
Lung abscess could be a possibility, but in lung abscess there will be a fever with rigors, and although chest pain could be a possibility in lung abscess, and then shortness of breath could be a possibility in lung abscess, but I think usually fever with rigors is a possibility. So it's a less likely possibility. Any other?
Lung cancer, bronchiectasis, COVID-19. these are coming up.
Yeah, so lung cancer, again, weight loss would be there, and then so that could be one possibility if there is some other features associated with that. COVID-19, yes, I would consider COVID-19 as one possibility. It's a short history, shortness of breath, coughing of blood bhi ho sakta hai, can also happen, and an episodic chest pain. So yes, COVID-19 is one of the other differential diagnoses which could be present. What about this? Is intermittent in nature, shortness of breath intermittent, then pain intermittent. Any other thought coming into mind? What about pulmonary embolism? So
COPD, the other is
again, bronchiectasis, somebody said bronchiectasis could be a possibility, but usually there is a copious amount of sputum in bronchiectasis, which is not there in this case, so a bit less likely. Acute bronchitis could be a possibility, but usually fever doesn't occur in acute bronchitis. So maybe infective exacerbation of acute bronchitis could be a possibility. So,
Tariq,
yeah,
they want to see the next slide.
yeah, yeah,
Pulmonary
yeah,
embolism is coming up, but they want to see the next slide for more detailed
yeah.
symptoms.
So I think that just I think I can move on. So these are the differential diagnosis with the with and the some of the diagnosis we discussed that the favoring this data, some of the diagnosis not favoring the data, and what based on the priority, what we can consider. Pulmonary embolism is one possibility, COVID-19 another possibility, pneumonia is third possibility, and then I think low down on the list, maybe if history is prolonged, we can take further. So other diagnoses can also be considered. So what we have done, that we have analyzed the data in depth about the pros and cons of different conditions. So just want to emphasize on that. So what we have done, the diagnostic challenge, this was actually a diagnostic challenge, although simple case, involves considering each piece of available information and determining the most plausible explanation for the illustrated pattern. It often entails what? Careful observation of the patient, appropriate history taking, accurate performance of examination, generation of hypothesis or a diagnosis, appreciation of relationship between each piece of data and each hypothesis, and attempting to confirm and deconfirm a hypothesis through appropriate ordering of tests. So this is the sequence of event we follow in diagnosing a patient. Now, the models that presume careful analysis of relationship between signs and symptoms and diagnoses are the hallmark of clinical practice, which we just discussed. And this is actually analytical model of clinical reasoning. Is it clear?
Yes, there is a hand raised. I'm not sure whether it's related to the previous
Okay.
question or the question. The hand is raised by Galaxy A22. I don't know who this is.
Mhm. But I think what I explained, that this case was presented, and then there was a discussion on what could be the supporting evidence,
Right.
what could be the
It's
against
related
evidence,
to the previous question. Okay, let's
and,
move on.
and this is the analytical model of clinical reasoning. Now, you see in this slide, presenting features A, B, and C are written here, and then the arrows are related to symptoms. So for different diagnoses, what is the weight of different systems is emphasized here, and that's how you diagnose a patient. You made your different diagnosis 1, diagnosis 2, diagnosis 3. The B symptom was in this case, in this hypothetical situation, is more favoring that diagnosis. So diagnosis 1 was made. So now causal rules linked features, signs and symptoms to categories diagnosis. Analytical reasoning are adopted every time a clinical teacher admonishes a student to be objective and carefully consider all evidence available before generating diagnostic hypothesis. Now, this is another case. I'm not going into detail of this case, but I think 52 years old man is brought to the emergency room at 6 a.m. in the morning because of shortness of breath. The shortness of breath had occurred suddenly and had awoken the patient from sleep. He vomited a small amount of bile, complained of chest pain, and was worse on deep breathing. He gives history of coughing up a small amount of blood, and for the past few days, for a week, he had been feeling unwell and sore throat. He complained of having experienced fever and chills on several occasions in the past, and he had awoken tightness for several days during the past week, but settled after a while. His past medical history included diabetes. Now, what is the most likely diagnosis here? So if you see most of the clinical, although he's a male, there are some associated symptoms are different, associated diagnoses are different, but I think more or less symptoms were similar. So the same differential diagnosis would come into, although he's a male, but the symptoms are similar. The almost similar differential diagnosis based on pros and cons would come into your mind. Now, what is that? In the next slide, if a similar case or more or less a similar case is encountered, sometimes later, the same differential diagnosis will come into the mind of the learner. Clinician, without generating usually the analytical approach, and this is known as non-analytical model of clinical reasoning. Now, as you become senior, you see a number of cases and with similar clinical features. When history started, clinical features are said, and then based on the clinical features, you straight away diagnose a patient. And those are the clinical scripts or illness scripts which have been developed over the times in your mind. And just listening to those script and matching those script to the clinical feature of that patient, you diagnose a patient straight away without going into depth of analysis. And that is known as analytical model of clinical reasoning. And you see, repeated application of knowledge in the diagnosis and understanding of real patients lead to formation of illness scripts in the mind of the learner. And these are the illness script, then you diagnose patient very quickly. So you see pattern recognition. These are presenting features A, B, C, and D. And then this patient you have seen maybe 3 years, maybe 1 month back. And then you have these patients, 4 patients, 3 patients with symptoms A, B, D, and F, B, D, G, and R. And these 3 patients, if you see the top one matches the most, A, B, D, and F. So most likely diagnosis could be related to that diagnosis. So that is again analytical. You match your clinical features with the illness script into the mind and diagnose the most probable diagnosis. Sometimes all features match. Sometimes most of the features match, but sometimes you have then probable diagnosis and then differential diagnosis. It has been argued that ability to use non-analytical basis of clinical reasonings makes increases with expertise. They become a professor usually do this in a non-analytical way, or illness script. There are hundreds of illness scripts into the mind of the professor, and then that professor uses that, so they do see very quick patients. The use of pattern recognition should not be advocated among medical students for fear of potential grim consequences, because they can do quick wrong diagnosis based if they do not analyze. So the recommendation is to do both non-analytic and analytical model of clinical reasoning. And in some cases, in complex cases, you do both analysis of you do a pattern recognition for the seniors as well. You do pattern recognition, but for a complex cases, use some analysis as well. So it should be oscillation between analytic and non-analytical reasoning, which is recommended. So clinicians override, recalibrate, and rebalance their decisions through dynamic oscillation between analytic type 2 and non-analytic type 1 processes. So again, that's what I said, that there is a need for a senior clinician again to use both analytical and non-analytical. Yes, they start with non-analytical, but I think in complex cases particularly, they need to analyze some of the things as well. Not in maybe in that depth, but they use. So here you see another way of maybe defining and discriminating feature of a set of diagnostic hypotheses for acute arthritis. Now, this patient presented with acute knee joint pain of the right side and recurrent in so you see in the center problem representation. This was a problem representation. Now, what are the discriminating features? What are the defining features? Chronic, if it is chronic and one joint and the joint involvement, it could be either osteoarthritis or it could be gout. And if it is a monoarticular, it could be either gout or a septic arthritis. And for defining features for gout, it should be episodic, it should be recurrent, male sex, infection, it could be discrete single joint with high grade fever and rigors. And osteoarthritis, multiple joint involved, and there is a long-term declining functioning. So you need to identify discriminating features and defining feature of a particular problem presentation, and based on that you diagnose the patient. So this is another way of doing clinical reasoning. Again, if you see here, another representation, you take a history, data acquisition, acquire accurate problem representation, as I discussed earlier in the earlier slide, generation of hypotheses, and search for selection of illness scripts and diagnose the patient. So again, I think the illness script of the mind play a role here. So recommendations for clinical teacher. Clinical teacher can use several strategies to promote development of strong diagnostic reasoning skills.
Dr. Tariq, may we request to please have just not more than 1 minute?
Yeah. Just I'm finishing in 2-3 slides are left. Quickly, I'll finish that. So clinical teachers should articulate their own problem presentation. I'll skip this. So clinical teachers can evaluate learners' performance on the basis of the expected performance at all development levels. We already discussed, and provide cognitive feedback. Feedback is one of the most important things. And there is a sparse literature in this, and there is a potential area to do research. I am also doing this to see how residents and students diagnose. This study is underway right now. Thank you so much for your attention, and I hope if you have any questions, I'm ready to answer.